The GeriPal podcast is brought to you by Archstone Foundation, preparing society and meeting the needs of an aging population. And now, here are your hosts.
Welcome to the GeriPal podcast. This is Eric Guadera.
This is Alex Smith.
And Alex, we have two guests with us today joining on Zoom.
We have two guests with us today. We have Lee Jennings, who is Division Chief of Geriatrics at the University of Oklahoma Health Sciences Center, and she is a geriatrician and health services researcher, and she practices primary care geriatrics. Welcome to the GeriPal podcast, Lee.
Thanks for having me.
And I should also mention Lee's a former UCSFer. Woo, woo. And we have Chris Callahan, who is Chief of Research and Development at Eskenazi Health, which is a public health hospital, and is also Professor of Medicine at Indiana University. Welcome to the GeriPal podcast, Chris.
Thanks for having me. I have no connection with San Francisco, but I have seen your bridge.
Well, we're going to be talking about comprehensive dementia care. Both of you had recent publications in the Journal of American Geriatrics Society, JAGS. Would love to talk about both articles. But before we do either of you have a song request for Alex?
You know, Lee's in Oklahoma, Alex, so it would be great to hear some Woody Guthrie.
Woody Guthrie. Here's a little This Land Is Your Land. This land is your land, this land is my land, from California to the New York Island, from the Redwood Forest to the Gulf Stream waters. This land was made for you and me. As I was walking that ribbon of highway, I saw
add a little twang to that.
That's the right way to do it.
Well done, Alex.
Thank you. Chris is a master writer of parodies, by the way. He wrote this terrific parody for the retirement of Robin Barr to the tune of that Shallow song from A Star Is Born. And we played that at the last Beeson meeting. It's a lot of fun. But that's a non sequitur. We should get to the topic of today. Comprehensive dementia care. What is comprehensive dementia care and why do we need it? Lee, do you want to start us off?
Sure. I think kind of in a nutshell, I think comprehensive dementia care is care that is longitudinal. It's care that is dyadic, meaning that it's caring for the individual with cognitive impairment or dementia and also the family caregiver. It is care that's comprehensive, meaning that you're addressing medical, behavioral, social aspects of the disease. And it's care that really isn't just within the healthcare system, but that reaches into the community because that's where people spend most of their time is at home. And so care that addresses, how the individual lives outside of just that doctor's visit.
Oh, that's wonderful. I like how Dr. Jennings started with it longitudinal. I'd like to think of it as a journey of care. It's a journey for every person living with dementia and their family. And I think when we do it well, we walk along that journey with them.
And when we think about comprehensive cancer care, dementia care, how important is it that it's focused on like the disease, dementia, versus like you can have comprehensive cancer care, comprehensive heart failure care, or should we be thinking about this as like comprehensive person care?
Well, I think this has been true of a lot of our collaborative care programs, because as you mentioned, Eric, there's these programs for many different chronic conditions. Dementia has been a bit of a challenge for all of us because, like Lee mentioned, it's dyadic in nature, and so much of that journey is taking place outside of the healthcare setting. And it was sort of our first order of business to be able to develop comprehensive care for this particular illness. And but one of the things that Lee points out in her article is this unmet challenge that we have with also helping that person manage their comorbidities.
Dementia affects everything else. You know, how do you manage your heart failure if you have cognitive impairment and you can't remember to take your medications? We think about chronic disease management for many other conditions as self-management, right? I'm going to teach you about diabetes and you're going to self-manage your condition and that'll help keep you out of the hospital or whatever. But in dementia, that approach doesn't work necessarily in the same way, because it is really about teaching a caregiver or a family member or a friend to help that individual self-manage. Right. And thinking about where the individual maintains that autonomy and ability to care for themselves and where they're beginning to need more support. And not just support for the individual, but support for the family member who may be an older spouse, who may have their own health conditions. And so I think we really have to think more comprehensively about what care looks like when we're talking about people living with cognitive impairment and thinking through how it impacts every other aspect of their care.
And Lee, can you give me an example? Let's go to the UCLA program. And specifically, we'll talk a little bit about your paper with Dave Rubin. But before we do that, can you describe what that program actually looks like? Because it's been one of the long-lasting programs out there around comprehensive dementia care.
Yeah. And I have to say, I have to give a shout out to Chris on the program, because the program that I helped evaluate at UCLA is really based on a program that originally came out of University of Indiana. And so the UCLA program is a partnership with a dementia care specialist who's a nurse practitioner with primary care. So these patients are in the UCLA health system. They're referred by primary care. And it's really a co-management model. So the idea is there's back and forth between primary care and the dementia care program about the patient's needs and about interventions to help the patient. It's also very actively partnered with community organizations. So it really is designed to reach into the community. They were partnered with Alzheimer's Association, adult day health programs, Jewish Family Services, a myriad. And it's by design, because again, most of the care people need is not at the doctor's, it's at home. And then the model also really strives to address medical aspects of care, social aspects of care, behavioral aspects of care, really systematically. And again, it's longitudinal. It's not just a one-time consultation program, but this is a program that people really enter into and stay into until death.
My question is, and this kind of leads into your paper as well and what you did in this specific paper, why haven't comprehensive dementia care programs been adopted widely? Why is it that Eric, slip of the tongue, says comprehensive cancer care? Because we've heard that phrase over and over and over and over, but we haven't heard comprehensive dementia care because it hasn't had the same sort of uptake in this country.
Well, one of the things that Lee just described are all of these interventions that some people might place outside of traditional medical care. Some people might place those interventions, in the responsibility of the family. Some might say, well, those are wonderful interventions, but that's not part of the statutory authority of someone like Medicare. And a lot of the interventions that we're talking about within the comprehensive umbrella, they're not pills, and they're not procedures, and they're not diagnostic tests. They have a lot to do with education, and support, and really helping that family keep achieving a quality of life. And so we have reasonable arguments as a society about which of those interventions ought to be under a medical benefit versus what are part of a family or a community responsibility. And I think this is one of the unique challenges of dementia, perhaps as compared to cancer or chronic kidney disease.
I was going to say a lot of the services, right, that these comprehensive dementia care programs provide are not necessarily in face-to-face billable Medicare visits, right? So there's not the traditional, and for large part, our country still operates under fee-for-service Medicare, right? We have some value-based programs, but in large parts, fee-for-service Medicare. And, we asked our dementia care specialists, like, how much of your time is spent in kind of a billable visit? And they said less than 25%. So 75% of what they're doing is not something that they can, put a code down and bill Medicare for. So these programs, the payment model for them really doesn't work well in kind of our traditional structure. And so it's going to require kind of thinking outside the box about how we pay for these things. And the benefits accrued, right? So, if you reduce acute care hospitalizations and you save Medicare money, but the health system incurs the cost, or the physician group incurs the cost of the program, those are not aligned well. So it creates a problem where you have somebody bearing the cost and somebody else reaping the benefit. And we've got to figure out how to remedy that.
Well, Lee, can you describe a little bit about I'm going to spend some time on particular programs. What was the benefit of, in the multiple papers published, including your last one in JAGS, what are some of the benefits that you're seeing with your program in particular?
Well, I'll talk a little bit about the last paper in JAGS, and then I want to say something about the body of work. So in our last paper in JAGS, we looked at acute care utilization. We looked at end-of-life care, particularly hospice use, and we looked at time to long-term care nursing home admission. And what we found was that as compared to people with a diagnosis of dementia within our health system, but not in our program, we found that we were able to reduce ED visits. We were able to reduce hospital lengths of stay. And we were able to have more people enrolled in hospice, use hospice in the last 6 months of life. And then also replicated our findings from a prior study that showed that the program delayed time to admission to long-term care. So those are outcomes that people care about. Staying out of the hospital, being at home more, getting better end-of-life care, dying with dignity. Those are things that are important to patients. So, and then if you look at the whole body of work, and we're one of several different programs of similar models, and they've actually, achieved the triple aim. If you look at it, right? They've improved care. They've improved quality of care. They've improved outcomes like depression and behavioral symptoms and caregiver strain. And now we're showing utilization, a decrease in acute care utilization and costs, right? So we've achieved the triple aim, yet there's still this scalability and this implementation barrier that we're trying to overcome to make these programs more widely available.
I think, this is somewhat of we began to chase our tail a little bit, because if you look at Lee's team's work, and we sort of see each one of these as the next barrier, like, does it work? And we think we have evidence that it works. And then, does it work in an efficient manner, often defined by saving resources or reducing cost. And we say, yes, it does that. And then we come up against a couple of additional barriers, one of which Lee already alluded to, and that's we're saving money for Medicare. We're not necessarily saving money for any given health system or any given family. And the cost to a family for some of these, interventions in this overall bundle of care are substantial. And some of Amy Kelly's work, for example, has shown that it's even greater than you see with other chronic conditions like congestive heart failure, these out-of-pocket expenses. But we also have other barriers, and one of them is workforce, which is a deep-seated issue in geriatric medicine. But we're also talking about a workforce for advanced practice nurses and social workers. Then I would just highlight one other thing about Lee's study And that is another workforce problem where she has a team that's able to match claims data and their patient care data with Medicaid or with Medicare claims. And this is really hard work. There's just not very many places in the country that do this well, and particularly do it in a way that has such practical ramifications. But one of the things that I think all of these articles point to, and the other article that's in this particular journal points to, is that if we could align incentives and if we had funding for this bundle of care, we might draw people into the workforce and we might stimulate innovation in how to get these programs to work even more efficiently or line up with community and patient goals.
One of the challenges I could see also is when we're talking about this bundle of care, I'm also getting a sense that the various at different sites, they're doing different bundles. So, for example, we had not too long ago a podcast on the care ecosystem. Again, showing great outcomes as far as improved quality of life for those with dementia, reduced ED visits, reduced caregiver depression and burden, but a different model than what Lee was talking about, and Lee said hers was kind of based on your work too. Like, how should we think about this, given that it's not like one standardized pill?
Well, one of the things that the other article that Lee was involved in this month of JAGS does is try to boil down a little bit what the essential components are. And you heard that from Dr. Jennings at the beginning, what some of these essential components are. I always think, though, if you were explaining this to a lay person or your own mother, how much they would look at this and say, well, that's just common sense. Why would you have to tell someone that having made a diagnosis, you should reveal it to the family? And, having told them about this very difficult diagnosis, you should, walk alongside them. And there are a lot of them that seem fairly common sense. But when you boil down the active ingredients the way Lee did, these programs begin to look very similar.
Yeah, I agree with that. I think that that the other thing to remember is that not every healthcare system is the same. So it's okay for us to have some variety in how these things are implemented in different places. Sort of like, you have the pillars of the intervention, but the shape of that pillar, the design on it might be slightly different, but the core of it is the same. And I think those core components are across all these different interventions, but the individual implementing it or the way that it reaches into the community versus the healthcare system may be slightly different. And I think that's okay because, again, the University of Oklahoma, where I am now, looks very different than UCLA, where I was when I began this work. And we need the framework that's adaptable enough to be able to be applied in the different systems to make this care more scalable because we're really not meeting the needs of patients and families widely right now.
We are not. We are so not meeting the needs of patients with dementias and their families. And one of the things I loved about your editorial, Chris, I should say that you co-wrote with Kathleen Unroe, who we had on a podcast previously, talked a little bit about optimistic. But one of the things I loved about it was the outrage at the beginning. Given the evidence that comprehensive dementia care improves outcomes for persons with dementia and their caregivers at cost savings to Medicare, why isn't this care as widely available as MRIs or total knee arthroplasty or hemodialysis? What on earth? What kind of evidence do we need? We have mountains and mountains of evidence so far. Why is this such an issue? And why can't we move forward with payment reform to get comprehensive dementia care in place? What are your senses of the barriers that are in place to making this happen? What's it going to take? We have so much evidence. Do we really need more evidence?
Yeah, I think one of the fun things, about this intervention that Lee mentioned is a different group picks it up in a different setting, with a different group of patients, and they adapt it, and it is adaptable. But even in a single organization, doesn't matter where you are, if you were at an academic medical center, a community health center, urban, rural, each dyad, the patient living with dementia and their care partner, is unique. And you have to tailor this intervention to that unique dyad. And that begins to present some problems for payers, in terms of understanding, well, what competencies, should I expect in a purveyor of this particular intervention? We don't let people just open up a hemodialysis, unit in their garage. Maybe one day that will be possible. You expect certain rules and regulations around competencies. And so there is a notion that a payer like the Medicare needs to understand, what are you doing? How do I know if it's quality? And how do I know if you actually did it? And as we were saying earlier, some of these things that we're offering as active ingredients and important ingredients, they're not less important just because they're not part of this medical model. They're not part currently of Medicare statutory authority. Things like, we might be helping through a community service agency, a family remodel their bathroom, which might be the difference between them going to skilled nursing home or staying in their own home. And by the way, might cost less than a couple of the, prescriptions they're taking on an annual basis. But that mismatch is one of the big problems. The other is we also have an issue with the workforce, and I won't repeat that, but if this became widely available and with a benefit that would support it the way we support other interventions, we'd have a boatload of work to do to build our workforce in this country.
Yeah, go ahead, Lee.
I just want to add on that. I also think we need to be thinking outside the box a little bit about workforce. So, for example, this concept of a pyramid or a tiered approach, right? You might need a very intensive healthcare-based nurse practitioner intervention for a subset, but you might do really well with a community health worker-based intervention or lay health coach intervention for others. And I think we need to think about it as a population and think about, we have to have some interventions that are $10, not $10,000 to really make it be scalable. And I think thinking about workforce outside of the box and thinking about what Medicare will cover with regard to workforce. Community health worker interventions are largely not covered by Medicare, to my knowledge. So that would be an example of a payment reform that might make some of these home and community-based interventions more scalable or more available to people.
Yeah. So, again, going back to the care ecosystem, which we had a previous podcast on, health navigators, lay health navigators were the main ones doing the intervention. And they were all taught through this study. And I loved about it because you could actually bring up their teaching slides, how they taught the health navigators, all free to use, which is, I think, amazing. And then that pyramid kind of shrinks. I guess one question is on the top of that pyramid, like going back to my misnomer in the beginning, calling it a comprehensive cancer care. I think part of the reason is like way back in the 70s, we started having comprehensive cancer centers. And you can actually, pull up from the National Cancer Institute, where are these national cancer centers, and there's specific requirements around transdisciplinary care. Do we need the same thing in dementia care, where we have comprehensive dementia centers that are held to these higher standards that do research and or do we have them already?
There's some that approach that, Eric. I think, though, they're kind of put together with duct tape and baling wire. which is a Midwest metaphor. So
it's great. I love it.
Any help?
I love it. Makes a part of me that grew up in Michigan very happy.
Yeah. Well, Lee knows what it means, but the one of the reasons that it's so hard to sustain these, say, over a decade, is because you have to patch them together. The NIA Impact Collaboratory is beginning to build that infrastructure for pragmatic trials, not necessarily comprehensive dementia care services. And then on the research side, of course, you have the Alzheimer's disease centers, but you don't have the same kind of fuel for comprehensive care in terms of funding that you have for cancer. But there is a debate there, if that's the way that we want to go. Lee mentioned we need to learn to do stuff, for a dime instead of $100. And how many of these broken out, comprehensive X, care centers do we have when the patients and their caregivers just see a person? And I think this is where the field is wondering, is there a way to sew this, more neatly in with primary care and to work more collaboratively with primary care and some of our other specialty colleagues? Or do we just need to move it all within a comprehensive dementia care network? I think that's an open question, but it's part of what we're saying. We need some support to innovate along those ways. Even now, though, it's pretty sad if somebody has to drive, from rural Nebraska a couple of 100 miles to get to the closest comprehensive whatever center. Everybody would like to get care close to their home.
Yeah, I think it strikes me that you don't want I'm thinking about some of my patients in primary care, and if they had to go to their comprehensive cancer care clinic and their comprehensive memory care clinic and their comprehensive heart failure clinic, right, they're exhausted, they're burdened. And so I do think that the idea of how we move forward with what is comprehensive care and how we pay for it is probably broader than just dementia. Dementia is probably a prototypical illness, but it could be applied more broadly to geriatric care or care of people with chronic conditions. Because primary care doctors, I'm sure, and other clinicians would love the opportunity to think about, how do I provide comprehensive care to my population of patients? And they face those same barriers with payment. And if you get paid to titrate the medication only if the patient's in front of you, then that creates an incentive not to do phone management, right? Or not to do, and we kind of have an opportunity now with COVID and the kind of the resurgence of telemedicine. I know where I am, we see a lot more of that. We've been more efficacious, I think, in trying to reach some of our homebound patients and our rural dwelling patients. And so I would love to see this sort of spur how we think about delivery of care in a different way and what we reward and incentivize with payments.
I love that. And we've had several episodes about the challenges as well of telemedicine. Like, we have a forthcoming podcast about how do you do a cognitive assessment over telemedicine, right? Incredibly relevant to today's topic. Here's a question for you. So our listeners are, we get about 5,000 downloads per podcast now. Thank you, listeners. We appreciate it. It's like double the size of an AGS plenary or a palliative care plenary or a GSA plenary. But our audience is overwhelmingly clinical. So these are clinicians, on the ground clinicians caring for older adults, caring for people with serious illness. What are the takeaways? Because enormous part of what you're talking about here is like health policy implications. Are there some takeaways for practicing clinicians on the ground now today and what they can do, either as clinicians, one, or two, as people who can advocate for health policy change on a national stage? Like, what's it going to take to get to move the levers to actually create comprehensive? Is this something that Congress needs to do, or is this something that Medicare could do by itself? So first, clinicians themselves, what can they do based on this? And then second, what can they do as citizens who are interested in advocating for change?
I think one thing that we'd really like clinicians to start communicating to their patients and their other stakeholders is that there are things that work. Stop saying nothing works. Stop saying things like this is a terminal illness, and stop saying, let's not diagnose it because there's nothing we can do about it. That's just demonstrably wrong now. It is a journey that is going to change over time for this patient and their family, and there's a lot you can do to help them along the journey. And it does not have to be defined by a prescription pad. If there were one thing I was going to tell somebody who says that I have zero resources, there's no way I can even do one thing, it would be, well, then take the time to find out what your community resources are. At least send people to the places that are set up to help them. And your diagnosis and your credibility as a provider will open doors to them for these community services.
I love that too, because it's, one significantly underutilized community resource is the Alzheimer's Association, which really I didn't really start thinking about until both during and after geriatrics fellowship. Lee, were you going to say something?
Yeah, I was just going to add to what Chris said. I think as a clinician, you can make a diagnosis, and that is really helpful because it colors the rest of the care of the patient. And then the second piece of that is just what Chris said, is refer to community resources. Alzheimer's Association is probably the most widely available resource across our country. And then I think as citizens, and both as clinicians as citizens, and patients and families as citizens, is demand this care. We all have smartphones. Why do we have smartphones? Because it's a relative advantage and we've demanded it and we use it. And I think there's a similar kind of, similar concept to the dissemination of a new innovation in this care model is that the consumer demand hopefully will help drive some of this. And I think I have to give credit to Alzheimer's Association, to Hartford Foundation, to AGS for beginning to increase the awareness about the success of models like this JAGS. This podcast, I think there's a real need to let people know about this model. Why do people go to NCI designated cancer centers? Because they know they exist and they want the best cancer care. Why wouldn't you want the best dementia care? And I just think that's part of driving this forward, is that demand for these models. Why do we have laparoscopic surgery? Because people want it, because you have better outcomes, right? It's less invasive, and there's clear relative advantage for this. There's clearly something we can do for people living with dementia, and we should be demanding that availability to drive it.
And if you had a magic wand, you can make any policy change happen. What specific policy? You have one. The magic wand is about to run out. You can make one policy change. What would it be?
I would take this bundle of services and I would put a price tag on it that Medicare was willing to pay with all the appropriate, regulatory controls in place. That wasn't just enough to keep a organization from, losing their shirt, but was enough for them to thrive and to innovate.
Lee, that magic wand is on its last string.
And I think similarly, some kind of per member, per month payment that would make this accessible for people to be able to use and make it reasonable for healthcare systems to implement.
And can I ask how much, for example, like the UCLA program, how much does that cost per participant?
I can know. Hold on.
And it's also a tough question to ask because it's cost to who? Cost to the family?
Well, it costs to the health center who's running the program. Yeah,
So do you weigh in the health savings that Lee's demonstrated from?
No, just the overall cost. The overall cost of the program, not the cost benefit. For example, amyloid PET scans. What do they cost? Like $1,000 per participant. 1,000 to 2,000. A lot of people advocating for them.
Look, but although Chris just said that we shouldn't diagnose it because there's nothing we can do about it. We know we can do something about it. I know it's somewhat different because amyloid PET scans and other such tests are more about can't predict.
I'm just trying to get a baseline sense.
Another controversial.
I am not advocating for amyloid PET scans.
Oh, okay.
we can make a diagnosis a lot less expensive than that. But I do think you'll be, surprised. Many people are surprised what it would take for a per member per month. And yes, you can pay for it. You get rid of a couple of medications, but we're talking about per member per month in the couple of $100 range. You can provide these services, and so over a period of a year, you're talking $3,000 to $5,000 per beneficiary, especially if you add enough, for this notion that you do have with other conditions like heart disease and cancer, where you can innovate on some of the margin the organization can make. It would draw people into the workforce that way as well.
So $300 per patient per quarter. So $1,200, and we saved about $2,400 per patient per year. So
$1,200 a year.
The cost, the confidence interval overlaps, so it was cost neutral. So in that study, once you accounted for the costs, but the point estimate was that you saved about $300 a patient.
Although this also. Does that include like the So one of the points Chris makes is that these programs have been supplemented by research funding, NIH, CMMI, et cetera, community services, family out-of-pocket costs. My question is, and Chris, you talked about this in your article. I wrote a blog post early on that about what if palliative care doesn't save money? Well, does that mean we shouldn't do it? What if comprehensive dementia care doesn't actually save money if you were to add up all those ancillary costs? Does that mean we shouldn't do it? Right?
No, this has always been sort of a holy grail for depression care, over 50 years, if not 100 years, that the argument for it was going to save money. There are a lot of things that we do that's not their metric. Many of these expensive interventions, whether it's a bypass surgery or hemodialysis, nobody is looking to see, do they save the country money? Healthcare itself, is an expensive endeavor. I think one of the things that we've hurt ourselves, arguing a little bit for is this notion that if we finally, pick your condition, if we showed we saved money, by gosh, manna would rain down, and it doesn't. And that's part of what we're talking about, that for our own, research enterprise and for ourselves as clinician researchers, you just have to recognize that multi-step process, that your p-value is not going to be the thing that, moves the country. And it may get, as Lee was saying, it may be the only thing that moves is advocacy from patients themselves and their families.
Yeah, I just can't drink the Kool-Aid that everything that is beneficial has to be cheap. Good care may cost some money. But at the end of the day, let's focus on paying for good care, not things that don't matter. Care that's not helping people, interventions that aren't improving health outcomes or quality of care. Let's pay for good care.
Well, I want to thank both of you for joining us today on this podcast. We will have links to the JAGS articles on our GeriPal webpage. But before we end, maybe we can get a little bit more of This Land Is Your Land.
A little bit more This Land Is Your Land. Here we go. I've roamed and rambled and followed my footsteps to the sparkling sands of her diamond deserts, and all around me a voice was sounding. This land was made for you and me. This land is your land. This land is my land. From California to the New York Island, from the redwood forest to the Gulf Stream waters, this land was made for you and me.
Lee and Chris, thank you very much for joining us on this podcast.
Thank you, Chris.
Thanks for having us.
Thank you, Lee.
And all of our listeners, thank you for your continued support for the GeriPal podcast. If you have a second, please share this on either Twitter or Facebook to spread the news about the GeriPal podcast. And a big thank you, Archstone Foundation, for your continued support. Good night, everybody.